a miracle how much you have done over the span of almost 30 years of your career. Maybe we can start with that, right? What that journey has been, how you started.
Sure. I had 30 plus career in healthcare. Started out on the payer side for about half of that with Cigna and then United Healthcare. Kind of did everything in the payer, moved around a little bit. Probably the biggest focus was the bridge between the business and technologies, what I did early on. And then I changed that into running affordability at a time when healthcare costs were increasing. Care was who I was working for at the time, and they were
Right.
feeling, kind of the impact of people pulling out, especially in small
Right.
business. So they really, for the first time, took interest in how do we reduce healthcare costs just to make our plans more affordable. And so they created these programs called affordability and uniquely
Nice.
for the first time used data and project teams and kind of Six Sigma philosophy to really look at different areas of care from a patient's perspective, women's
Mhm.
health, primary care, radiology, et cetera. And so got really focused on what moved the needle in each of those areas with outcomes and costs and was pretty successful within a payer. Under those programs, we shaved about $1 billion off of United Healthcare's fully insured spend. How many
Correct.
dollars they threw at the problem, how
Right.
many talented nurses and clinical people they put on phones, they just couldn't get past like a 10 or 12% engagement. A few of us who were at United Healthcare at that time said, you know what, let's go get closer to the providers. And so we formed a company back in 2009 called Rise Health, which was really about patient-centered medical home enablement. And we took those kind of sophisticated programs around medical cost management, cost and quality, and wrapped them around doctors in a way that we, would allow them to not only operate differently, but participate in kind of the reward, moving that downstream cost down.
Excellent.
But, that was way ahead of any kind of payment model. It was before the Affordable Care
Right.
Act, before we had any kind of risk models. And so we had a great model. We had great meetings. We took over primary care for Boston Medical Center, did some stuff down in Texas with what's now known Catalyst Network. We're able to move the needle, get doctors to operate differently. But until you
Right.
brought that big incentive plan, which is a risk contract, it was hard to
Right.
have a momentum in the company. I created a new one in 2012 called Orange Health. We rebranded it Citra Health, which is really, timing is everything because we had the Affordable Care Act, we had the Medicare Shared Savings Program that just came out. And so we just rebuilt kind of that same thing, which was patient relationship management. It was a call center to wrap services, care coordination,
But
care
incentives for
management.
doing.
There was an incentive. There was a risk, at that time it was upside only. That was before kind of downside risk, which came a few years later. But it
Correct.
really was able to, if they were successful, shift dollars. The pie of healthcare had increasingly gone more towards hospitals, where hospitals were getting of that, let's say at the premiums $1,000, 70 to 80% of that was going directly to hospitals. And so maybe not that high, but close. And the primary care docs were being squeezed more and more. They were having to see more and more patients. And so therefore care was less and less. And so it really was the opportunity to shift that and move it back. And we built one of the first ACOs in North Florida, ran about 12 ACOs around the country, kind of one of the first enablement companies, and did that for a few years and ended up selling that company to Cedargate, which still exists today and is a player in the value-based healthcare space. But while I was doing that, I was like, this is such a new space, and selfishly, I was
Right.
trying to sell into it. I formed the
Mm.
Florida Association of ACOs, which I still run today, about 13 years later, and it really does bring everyone in value-based healthcare together
Together.
in the state of Florida and outside Florida, honestly, because we've become such a known entity. So we have always, I think, for most of those years, about 70% of the ACOs got savings, and I think this last year, 92%. So
Wow.
Florida is a really great market.
Amazing.
Recently, a year ago, I went into Texas, kind of trying to do something similar there with the Texas Association of ACOs.
But what made you think that accountable care or value-based care could be the future? Like,
Said we were able to move the needle pretty significantly within the payer, but we learned what we couldn't do. And so, going outside of the payer and getting closer to the person who had the trusted relationship with the patient, which is their doctor, seemed smart to us. I think we were ahead of what we now call value-based healthcare. We saw the future. We knew that healthcare costs were unsustainable and somebody had to do something. That
correct.
seemed to be the right place to go. I think entrepreneurs tend to lead the charge, and certainly the biggest payer in the country, Medicare,
Yep.
putting out the first risk contract certainly pushed everybody else to get into this space. And so we thought when we started this back in 2009, or actually prior with United Healthcare, but
Yep.
2012 with the first risk contract, that this was going to move much faster, that
Hmm.
everybody by this time would be on one. But, it's not as easy as we'd all hoped, but we're getting there. And I think people that have been part of it are still very optimistic on where this is going.
No, absolutely. But you started off by saying that one of the issues was that the primary care physician, who's closest to the patient and therefore can engage, were already very busy, right? How are they expected to actually do the patient engagement? And we find that problem even today, right?
One of the first things that came out as part of patient centered medical home was top of the license, right? Let's get the physicians to work at the very top of their license, which means let's get all this other work off their plates and let them be the masters of diagnosis and really clinical decision making, and everything else should be able to be done by other people. Emerging of these contracts, it enables a lot more money to be flowed from kind of the bad place. And I don't want to say hospitals are bad, they're absolutely necessary.
No,
But
no,
we
from the
want less of
tertiary care
those, right?
space.
We want people that are healthy and at home and cared for in a
Yeah,
different way. So, moving those dollars appropriately to primary care builds a huge incentive, allows a team to be constructed around the doctor. And I
the
think,
doctor.
we all heard early on we got to transform doctors. And I think that's wrong. I think doctors went to medical school, they're pretty darn good at what they do, but let's put a team around them so they can do that. And let's make sure we got people that are doing care coordination. We got people looking at population health analytics to figure out the cadence that patients should be coming in, prior diagnoses that they want to make sure they address when the patient's in front of them, care gaps,
Right.
high risk problems, multi-chronic. You put all that in a record for a doctor and let them look at it quickly before they see the patient. The outcome there is pretty good. And then do all the other
You're
follow-up
basically
with team
making the
members.
doctor.
Incentives are huge. Those dollars that can come from these risk contracts is a great incentive to get off the mousetrap of fee for service. And also, I think, look at some of these new funds as investments in a new model.
I've spoken to a couple of doctors, even like health administrators in large health systems, where there seem to be some patients on fee for service, some on value based care models, different payers, and we are in a transition. So, how do you see sort of people deal with that transition, and how do you get doctors and the entire like team around them to actually shift behavior to start focusing on outcomes and focusing on that value based approach?
Well, I mean, getting every patient in a doctor's panel on a value-based healthcare is a great goal because it is hard to operate in two different
Ideal.
mindsets.
Yeah.
And I do think that CMS was pretty smart. They created these what I call bridge codes to
Yep.
kind of help along that transition. So,
Correct.
when you have half a doctor's panel one way, and you've almost got to say, okay, we're going to invest in new workflows that even before a risk contract assume every patient's in a risk contract. Let's not try to
Okay.
operate and deliver care different way. Let's just rebuild our workflows to focus on a value-based healthcare environment and hope that the contracts will come. So I think the trap is that some providers look at them as additional revenue. And
Yeah.
so any patient that I can put into CCM, RPM, AWV that they want that did it, well, you got to be
Yep.
very strategic and make sure you're using them to truly manage a panel better, and those funds to be used to fund kind of this transformation in infrastructure, people, et cetera. And so the success stories are where they look at it that way. The not successful stories are the ones that see these
Look
codes
at it.
as just another fee for service and how do I maximize them? And so it's helping guide people the right way.
First. So how do we make sure that you don't get stuck in between this transition?
You have
Yep.
to, I think, maybe getting ahead to the end goal, which is transforming the practice workflow and building the right team to support a truly value-based healthcare model, and
Right.
start with that end goal and then go back and how do we get there? And if you look at
Hmm.
it from that perspective, then those codes are a different thing than I'm just trying to put more fee for service and more revenue into the practice, because which patients we put in those programs would be different with that end goal perspective versus just cranking more revenue into the practice. And
Right.
so I think it's all strategy. It's getting the doctors to see the long-term gain is really going to be these risk contracts and participating in them. So let's use this opportunity to plan and invest and fund appropriately. So I think it starts with the right conversation.
So, Nicole, if somebody is already on those bridge codes, right? Like there are practices, smaller practices who are already, let's say, billing for these bridge codes. They've invested in a team. They're already doing this for their patient population. How do you move them to then say that, hey, this is just not the end goal? And then how should the transition work from starting some of these programs to actually being on a full-fledged risk sharing, both up and downside?
I mean, it really is kind of what I just said, which is strategically looking at, I would go in and look at all the providers' contracts, how
Okay.
many are on any kind of value-based healthcare contract versus not, how many of their patients,
Hmm.
at what level, because you can say you have a value-based healthcare contract, but it's rewarding some of the early steps versus full panel management and full medical cost management of everybody that walks in your door. And so it's really kind of starting with evaluating where you are today and with the
Right.
end goal of how do you get to everybody's on a really robust value-based healthcare contract, and then showing them if that happens, how the revenue is really better for
Much
them,
better.
because at the end of the day, these we gotta recognize that these practices are small businesses, and this pays the bills, and if we forget
Yeah.
that and pretend like every doctor is doing this just because, they
Goodwill.
love care, which they can do that too, there is the ability to have those goals, but at the end of the day, you have to show them how this is better for their practice, it's better for their income. Honestly, it's win-win because it allows them to operate in a way that hopefully makes them a better doctor because they're caring for patients way more proactively, and then put a plan together to say, how do we use bridge codes and other mechanisms and bonuses from payers? And how do we go back to these payers and say, okay, I'm ready to move down this path a little more and you need to give me a better contract to do that, and put that plan together and start to take action on it. So
I understand. So, and when you have still consult with facilities or providers in terms of sort of doing this transition, educating them on how this movement will work, when the revenue actually starts looking better for them.
one of the companies I have is called Value Service Management, and it's another version of the enablement company I started back early on called
Nice.
Orange
Okay.
House. And so what we're trying to do, and honestly, we're very focused on long-term care and SNFs because we see that as the next big chunk of misplaced, medical costs that needs to be, all the incentives in that space need to be realigned where these nursing homes, SNF owners can really participate in value-based healthcare. But first
Right.
you got to show them how they can do that, because right now these facilities live very much on a bed day per diem, and then they bring in
Right.
some ancillary revenue to kind of cover costs, and they're very strapped in what people they can put in these places, and it's not good for the patient. They're trying to stay alive as a business. The patients don't get that robust care they could if the incentives were switched, and showing them that path. But these patients that go into these facilities, short term and long term, have much higher benchmarks, which means that there's a lot of better care out there available, and there's also a lot of opportunity to make savings, which these SNFs and long-term care facilities can participate in
So
early
today,
on.
as a SNF owner, when I'm operating, I know I get paid per diem. And I have multiple service providers coming in that provide different services, and I have some other revenue streams. But if I move as a SNF to a completely risk sharing model, as an owner, how do things change for me? So,
So I would start with kind of the Medicare Shared Savings Program. You control which providers come into your SNFs. You
okay.
can, even though I do believe that CMMI is looking at giving attribution to the nursing home. Right now, attribution under these models is
To
given
the
to the
physician.
provider that goes into the
Right.
nursing homes. And so when that
Correct.
switches, if it does switch, that's going to be a game changer for these facility owners. But even
Yep.
now, the facility owners still control who walks in their door and cares for their patients. And so they could form these ACOs, Medicare Shared Savings, or they could go get these contracts in partnership with the providers they allow to come into their facility even today. And so all
Amazing.
of a sudden, think about if you have 5,000 patients and the benchmark is $10,000, you're managing $50 million in medical costs. Just think
Seriously.
about that becomes your revenue for a business. And then if you
You
shave.
optimize the cost going there.
Right. And you put all these things in place that take you down using bridge codes, using, new workflow, new technology, et cetera, to really manage these patients to make sure they're not going in and out of the hospital, that you're really caring for them in the facility, all kinds of things.
Interesting.
And then if you save some of that 50 million medical
Dollars.
cost, you participate in that. And that's revenue today that you you don't even care about it as a SNF owner because that's somebody else. The provider gets paid for that, charge it. It doesn't have anything to do with the revenue in your facility. And so all of a sudden now you participate in a bunch of that. And I would say on the long-term care side, 10,000 is more like 100,000 or 60,000, depending on the severities.
Oh,
Those numbers add up really, really fast.
that's amazing. I think a lot of SNF operators, at least that we speak to, don't see this bigger picture. So I think it maybe the consulting arm really does have a lot of work.
Well, it's very nascent. It's coming. We were ahead of it, but I'll give you three great examples. There's three long-term
Okay.
care facilities. Sound Physicians, which has about 13,000 lives, made $80 million in savings this year.
Wow.
Long-term care facility, which has about 10,000 lives in Medicare, made 40 million. Bluestone, which is a physician service group wrapped around assisted living, where the benchmarks are smaller but still higher
Right.
than primary care, had 5,700 lives and made about 26 million. So that is revenue
And
going
that you're
into these
talking about in
facilities.
savings itself.
Yes, in savings. And
That's
so,
incredible. And
yeah,
have you worked with these folks?
so these are ones that I'm aware of. I know them. We have our own, which call it Sunflower ACO, which is about 60% long-term care. And so
Right.
we're trying to come in and help others get into this space. And those are just examples of good success stories. So it's a good space to get in. And it's doing God's work too, because it's win-win. All of this behavior is better for the patient.
Absolutely. Better for the operator. You make the operator in charge of really taking care of the patients. And in that case, and most SNF operators, unfortunately, don't have great margins in their current models. So if they can move to a risk
This is a
sharing
way to
model, I mean,
change all that in order to deliver better care. What's better than that?
very interesting. But yeah, so having said all that, unfortunately, if you look at even after the Affordable Care Act till date, healthcare costs have not come down, right? So what do we really need to do to start really impacting the costs? Because yes, it might be because of the additional codes, the risk-based coding and all of that, that the costs have continued to go up. But what do we really need to do? And I think you have the best perspective possible because you've seen all sides of the game.
Well, yeah, I mean, a lot of it is, when it's follow the incentives, right? And
Yeah.
for Medicare Advantage, which is kind of delegated risk from the payers on the other half of the Medicare population to big groups of organized providers, MSOs, we call them, similar to an
Yes.
ACO. But the rules for years rewarded risk coding. And so and wherever the incentives are is where everybody's going to follow. And so these groups got really, really good at risk coding. And so what happened is the trend for healthcare in our country didn't go in the right direction. Some of that's cost of living and you expect a certain percentage, but it outgrew these models aren't working. And so it really was because people became sicker on paper because of really good risk coding. And maybe it was appropriate risk coding. I'm not saying it wasn't, but it didn't change the cost trajectories. Recently, CMS, they did some things with the RAF scores. They didn't let them go backwards. They brought in the new risk formula V24 to V28, which, forced people to just, they were never going to recover from the 15% cut there. So it's forcing people to do what the ACOs have really focused on since the beginning, which is look at the back end cost of care instead of managing the revenue side of these businesses, which is what I see risk
Right.
coding as. It's really
Right.
going to how do we move the needle in
Cost.
inpatient, ER, post acute. And so ACOs, which always had a risk coding cap, kind of was
Right.
forced to go there. And I'm seeing Medicare Advantage show in other areas, which weren't as focused on the back end, start to move over and really get focused on that back end cost reduction. And even the ACOs are getting better at it.
And honestly, it's everything, right? It's not just the providers and the ICU and the surgery. It's also like and I look at different markets also. So let's say, even if you're going through a surgery, right from the medical device supplier to the medical to pharma, everything has different costs in US healthcare compared to the same thing and the same product and the same drug in another country. Then let's say, for example, in India, it has its own healthcare challenges. We are still a fee for service market. But I think access is a lot better. For example, like seeing a specialist, seeing a primary care doctor is a lot easier. And cost of healthcare is 100x lower almost. While outcomes of care are, unless you have a really complicated health issue, I would say they are fairly comparable. Where I think the US definitely exceeds what we can do as a country is the really complex problems. You have an advanced stage cancer or something like that. The input cost, yes, there's the doctor and the real estate and the general cost of living, but also I think the main products, let's say knee surgery, the cost of the joint, same joint in India is different from what it is in the US.
Well, yeah, I think there's a lot of things that go into that. I think our
Yeah.
system kind of grew between the employers and
Payers,
news companies and the big health systems. And so when you took the consumer out of all that, healthcare costs are going to rise because they just negotiate with each other. And, and then you bring in all these regulatory rules that's trying to make it better, but have all kinds of unintended consequences, which, you can't even put a plan together. Like for someone that's 60 years old, why are they paying in for maternal care? Because there are rules and regulations, and the Affordable Care Act even made it worse, which is now everybody has to have everything covered under the plan. There's no more kind of donut hole covers where you can say, okay, I'll take care of my primary care and my stuff and create a consumer focused system, and I'll just have
right?
insurance for catastrophic and things like that. Those
Which is
plans
kind
aren't
of
even.
what we have here.
Yes, and so they're not even allowed. So you've created this almost false marketplace, which keeps everything elevated.
I know.
And so it's hard to beat that. And so value-based healthcare hopefully is shifting things more to a cheaper setting, primary care, and more, preventative and wellness focused, less people getting sick.
All the problems are there. Unfortunately, the I think the mindset to look at that is not yet there. I remember you saying that your real passion lies in root cause healthcare, which is very interesting, right? If you could do that, one policy redesign, what would it look like?
Well, I mean, I would build a plan that was very much around incenting, cause healthcare, cellular health. Why does our body work the way it does? Why aren't we prescribing food as medicine and movement is medicine and things like that? Why aren't we looking at what causes us to get sick? And,
Right.
why aren't we prescribing detox stuff to get bad stuff out of our bodies that accumulate over just living and eating in this country, good
Yeah.
and bad? Why aren't we looking and testing for those things proactively in order to prescribe solutions way ahead of getting all of these chronic diseases this country is, overrun with? I mean, there's a huge transformation that still has to happen, even with value-based healthcare, 100%. There's still an opportunity for
Because
more root
value-based
cause.
healthcare is still trying to address the sick care part of the
Yes.
entire value chain.
Yeah,
Right? I mean,
exactly.
we're trying to make that better. We are trying to at least make that more outcome focused rather than input focused. I get that. One interesting question, Nicole, and since you see ACOs of different sizes, shapes, different kind of providers coming together to form ACOs, where do you see the maximum impact of AI coming into their workflows? And are there some sort of real world problems where you can already see things getting more efficient?
Yeah, I mean, I see AI creeping into everything. I mean, every aspect of healthcare, which is, super exciting, but also a little bit scary, depending
Yeah.
on how well it's managed. I think that the things that are really making impact today is in patient engagement. You can really cost effectively get to so many more patients, and that is important when you're kind of closing care gaps, when you're trying to schedule patients in on the right cadence to come in. And if you can outreach to your whole panel via AI very cheap, then you can use your people to really focus on the ones that you're just not getting to versus being, they're
Yeah,
right
yeah.
now they're focused on the easy ones. And so, you can, the stuff I'm seeing around conversation, I mean, you can have full input output conversations. If a patient calls the
Yeah.
office for an issue, you can have that conversation. Plus you can go dig in the database of who this patient is and say, while you're coming in for your cold, can we make sure that you close this care gap? Or we've noticed that you haven't seen your cardiologist in 3 months. I mean, all of that can be
Or
had
you're seeing all of that
very,
actually
and
being used?
and I'm seeing that today being used. Yeah, I was actually a demoed a product yesterday. It was kind of a central command center, and they're
Okay.
working for providers practices. And I'll give them a plug, Cena Health. But I mean, they really are using AI to almost take over 80% of the conversations of when patients
Inbound.
went into these practices. Yeah, which is
Yeah.
incredible. And even in an older population, which they thought wouldn't happen, and still pretty nascent in a lot of areas. I mean, it's still new, but it is being used, and it's being used. I mean, I think the timeline is going to move faster than other technology. I mean, it's just incredible how fast and build it, but deploy it, but also modify it and process improve it and get it back out there. So a lot of stuff is
That's
happening.
incredible.
I mean, I
Yeah,
think
and I think that just helps the physician build that team around them a lot more efficiently, right? Like what we spoke about, that you don't want the physician to be doing it, but you build a team around them. Now that team gets a lot more efficient, so they can do this at
Yeah.
scale and a lot
In
better.
AI. I mean, patients are, asking all the questions at home that they used to ask, had to wait to go ask their doctors. So they're coming into their visits armed with all of this information. So providers need to be ready for that. So yeah,
No, but I'm not very sure the providers like that at all.
I'm not going to say it's perfect because it's still so
It's fairly
nascent,
good.
but it's very
Yeah, one
good.
very interesting thing, the younger generation. So a lot of teenagers, I actually asked them that when you grow up, and people who understand AI and Chat GPT, they've been using it. And if you had a small health issue, would you trust a doctor, a human doctor, or would you first go to this AI doctor? And I would say almost 90% of these teenagers said that they would rather go to an AI doctor. And if they don't feel satisfied with the answer, they will go see a doctor.
It's true though, and that's actually creeping out of teenagers and lots of people are trusting AI. And so it's a little scary in that I don't think we've perfected it. And there's things called hallucinations and some,
Yeah, of
backstories
course.
out there. But overall, I think it's pretty amazing technology. A lot of the problems in healthcare are block and tackling. They're systemic problems. They're not bad clinical care. When someone goes into the hospital and they leave, no one's following up,
They're
so they get
workflow problems.
confused, and so it's things like that just that AI can come in and really solve. If you can take someone's discharge summary and explain it in a way that they understand what drugs they came in, what drugs got delivered to them, and what they should be doing
Right.
when they get home in a very easy way, you're going to prevent
Yeah.
readmissions without even having to go to the doctor. Now, I would rather them use AI to schedule them with their doctor, but sometimes you
Yeah.
got access issues and things. So I just think there's tons of ways to solve the same problem, and AI is definitely a great tool.
And is policy doing anything in terms of compliance, putting some guardrails? Because everybody in healthcare also seems to be using AI in some form or the other. And you seem to be fairly close to like policy changes and how they're thinking about these things. Kind of
So
control, limit what AI can and cannot do.
So a friend of mine runs, he's the COO for NCQA, and he came to the
Okay.
conference a few weeks ago, and they've rolled out kind of an advisory type of group around AI. How can these systems really, NCQA is a big certification, compliance organization. And so how can they
Right.
build something so that big hospital systems, et cetera, can be assured of the AI they're choosing and implementing doesn't go off the rails. And so there's that big task force happening. Another guy, I'll give him a plug, Brian Rotella, is building a legal counsel model around helping companies that, because he talks very smartly about the challenges of AI. And if you don't get ahead of the risk and compliance, he's an attorney, a healthcare attorney, you can really get in trouble. And so he's building a model to help companies who are implementing AI not get in trouble. And so I see all these things
Yeah.
happening with really smart people. And so it's a concern. We got to think about it, but there's people out there trying to solve for it.